Quite the case, I think, indeed. So welcome, everybody. Thank you for having me and inviting me. I'm really honored to be here. Indeed, like you say, I think a lot of the questions were already about this, so I'm very happy to share with you some information on how to protect all infants against RSV, and I will be mostly making a comparison between monoclonal antibodies and maternal vaccination. We've already talked about some of these topics, about nirsevimab. We've heard a little bit about maternal vaccinations, but I would hope to go a little bit more into depth during my presentation. Some conflict of interest is that my department has received funding from several other companies. And before we go into really in-depth about the current research, I'd like to take a short moment to remember why we are actually here and see some faces behind all the numbers that we're naming.
I was pregnant with Ramondre 2016, and he did pass away when he was 3 months and a few days. He was a healthy baby, always smiling. I never took him to a clinic or a doctor, but then he started struggling to breathe heavy.
So what I understand about RSV is that it's a virus, okay, which causes a respiratory infection in everyone, in adults and children. But in children it's quite severe.
When I came there, they told me, okay, come in, mommy, there's lying there. And he was lying so peacefully, like he was sleeping. And then I picked him up and I told him, Ramondre is mommy. Wake up, baby. And then he didn't want to wake up.
The other mummies who is pregnant and who is wishing to become pregnant, they must all know about the RSV, because I didn't know. And if I would have known about it, maybe I would have done something or take him earlier to hospital, maybe he would have still be alive.
Is that it's a systems problem. I will be talking a lot about vaccines, I'll be talking about virology, but it's in the end a systems problem, like Ziad was already touching upon a little bit as well. So why are we even doing this? This is a recent study in Europe where 10,000 children were included in a birth cohort, and we saw that in Europe overall 14% of children, of all children, in their first year visit a doctor for RSV, and 1.8 is hospitalized. So these are insane numbers, even though we don't even really know why you get hospitalized. So that's a big question. What causes severe disease? So in the past, we've always focused on these really susceptible children, right? The young, the small or the narrow lungs, or with muscular weakness. But actually, when you look at who is admitted, it's usually or mostly healthy term babies. So it's not really a matter of who do we protect. I think it's a matter of we need to protect all children. Now, how can we do that? Because we want to protect all children for the WHO Sustainable Development Goals as well. All children under 5 that we can protect against preventable deaths. And RSV is becoming one of those, it falls under that category. So you've already seen the picture on the right here, where indeed we make the case that actually when we say we need to prevent all deaths, we need to look further than high-income countries. Most of the deaths caused by RSV are in low-middle income countries, partially because of lack of access to the care they need. But actually a lot of the deaths are out of hospital. So how do we protect the children that are not in hospitals? Treatments will not make the difference. We need to prevent the disease. And so within this talk, I'm going to speak to you about what's been mentioned before, that RSV prevention is actually within reach. I would like to take you along with one of my greatest hobbies, which is mountaineering. You might think, why is she going there? But I swear I have a case for this. So in mountaineering, you're trying to find the way up, right? Everybody's always wanting to reach the top of the mountain because that's where you get the best views. You feel like you've really challenged yourself by challenging the mountain. And so you can compare this with the vaccine development. In the past, we've done great efforts to find our way up. As long as we reduce child mortality, we are happy. We're trying to find any way possible. But we don't always reach it. Sometimes we take the wrong route and it's a dead end. Currently, we're really close to that top. So that's what we're going to talk about then, the promising candidates that there are. But what if we have reached it? What do we do then? Do we just go back home? So what are the next steps? Now, this has been touched upon before as well. So the past has a very long history. The first vaccines were in development in the late 60s. But indeed, there was vaccine-enhanced disease, and that was a major setback. Only 30 years later were the new treatments in development, starting with IVIG, which wasn't actually all that efficient, and it was very expensive, and then was really closely followed by palifizumab, which I write here is in the past, because I think we're all sensing that it's soon to be the past. But the problem with both of these is the duration of protection. So indeed, you need to protect or need to re-administer every month. It's very costly, and actually the neutralizing capacity of palifizumab is a little bit limiting. And another picture we've seen before is this. So the major game changer, when we really found our right route, we stopped finding dead ends, is when we discovered by the group of Barney Graham what the pre-fusion protein on RSV looks like. So this is what I always say, the spike protein that COVID has, because most people know that. RSV needs this protein to be able to bind to a cell and then infect it. So if we have antibodies present that will bind to this protein before the protein and the virus can bind to a cell, then we are preventing cell entry and thus preventing infection. Now, there have been several epitopes in all these different colors that have been identified, and some of them have more neutralizing potency, so you can stop the fusion more than with others. And indeed, it's mostly the red, so site 0, that is very potent, and palifizumab binds site 2, which is not all that potent. Now, that's not the only lesson we've learned from the past. We've also learned, or already heard about motafizumab, which was more potent than palifizumab was, even though it was on the same epitope, but it did not reach efficacy, and actually it also had local skin reactions, so that stopped its development. More recently was septavimab, which was a site 5, so the second highest neutralizing potency, which was actually also, again, and it's a bit difficult to see, but it was more potent than palifizumab is, the current standard of care. But the problem there was that when it was used in the phase 3 trial, it was found that actually there was resistance in the B strain of RSV. And so that also stopped its development. If we look at more lessons learned, we now move on to a maternal vaccine, which is called the RSV Pre-F. This was a nanoparticle that was given to mothers during their pregnancy to then prevent RSV in the babies. Now, this study was largely done in the US and in South Africa, and even though it did not meet the primary endpoint to protect the children, actually it was the first proof of concept that maternal vaccination could work for RSV. There was a heterogeneity based on geography, based on timing, both seasonal timing and gestational age timing that made it yes or no, was it efficient or not. Last lesson learned recently was the CHAD 155 RSV. This is an adenovirus vector, so a different type of strategy again, so a different route again to find that top. So this adenovirus was expressing the F protein that we previously talked about, but also two other proteins, N and M2.1. And it seemed to be getting both a humoral and cellular response, but then later on it also did not meet efficacy endpoints. So from that we learned that maybe these three are not, or these three antigens are not potent enough to form a response. So where do we stand now? I already said we've taken several routes up. Some of them are dead ends, but we're reaching the top right now. For the sake of time, I'll skip this. So the question is, what top do we go to? The mountain I just showed you is the Dent du Midi in France, or sorry, in Switzerland, close to France, and it's known for its 7 peaks. So what peak do we actually choose to go to? One way you can explain this is in the target populations. So yes, we have maternal vaccination, where we make use of the placental antibody transfer, and we make use of the mother's pre-existing immunity. However, a major issue here is adverse events. We are looking at both mother and child. We need to protect 2 lives here. And so the safety concerns are actually taken really critically compared to, for instance, other adult vaccinations. Now, the other way we can prevent infections is by administering it to the infant itself. And there so to answer one of your questions, there we really aim to protect against severe disease. We don't want to protect all RSV, but we want to protect against admissions. The problem there is that infants are antigen naive and they have an immature immune system, so we cannot make use of their own immune system to boost their antibody levels. We need to give them it passively. That's different for older children, where we would aim for herd protection, but they do have pre-existing immunity, and so we could make use of that. And the older adults I'm going to leave to the next speaker. So currently there's a rapid expansion. The field of RSV vaccination has never been this crazy. And in the past, in red, you see how many candidates have failed, but also how many are still in development, which is quite a lot. And in the top bar, you see when we expect registration for these. So we're actually living in quite exciting times. At the time of writing this article, which was about half a year ago, maybe a bit more, the vaccine monoclonal antibody landscape had about 33 candidates. Since then, some things have changed, but what I'm trying to show you here is the amount of routes we're taking to the summit. We have the subunits, we have nucleic acid-based vaccines, we have particle-based, live attenuated, recombinant, chimeric, and immunoprophylaxis. So where do we even start when I'm talking about what is the current landscape? Well, I thought it'd be easiest to talk about the most exciting things. So when focusing on the pediatric population, we have our monoclonal antibodies and we have our maternal vaccine. Again, I won't focus on the older adults. So let's start with the biggest question of them all, right? Nirsevimab, what's that all about? It's a monoclonal antibody that's aimed at site 0, so the most potent neutralizing site. Yes, that's good. Then secondly, what we learned in the past is that sometimes clinical isolates, especially the B strain, can be resistant, just naturally resistant against it. But on the left image, you see that actually it was compared in a whole bunch of different clinical isolates, current clinical isolates, and all of them, it performed better than palifizumab did, and there was no resistance. So another checkbox, that was done well. What has been mentioned before on the right image and also in text is that it's efficient. It has 70% lower incidence of visiting your doctor, and it has almost 80% lower incidence of having admission. This is both at 5 months, by the way, because the whole point of nirsevimab is that we want to protect all children, not just the preterms, and we want to protect them with just a single dose. So if we look at making them or protecting them for the entire winter, we need to protect them for 5 months, right? So more or less. So I'm looking constantly at the 5-month protection because we don't want breakthrough infections. Clesrovimab we haven't heard much about yet. This is a site 4, so actually that was the 4th on the list, but let's give it a chance anyways. Clesrovimab is again a lot more potent than palifizumab is, as you see in the above left graphs, for both the A and B strains. When we look at clinical isolates, there is no resistance naturally occurring at the moment or in this study. And when doing a controlled human infection model, so you take healthy adults, you infect them with RSV after you've given them the clesrovimab, we see actually that there's great efficacy against lower respiratory tract infections. There is no clinical 3 results available just yet, so we just have to wait for now on how efficient it is. Now, a little bit of an honorable mention, and I know that I'm 100% biased because this is part of the work that I do, but there is one product in clinical development in a phase 1 trial at this moment, which is called RSM-01, which is sponsored by the Bill and Melinda Gates Foundation and in product development by their Medical Research Institute. It's also a site 0 targeted antibody, with an extended half-life, so it should be, just like nirsevimab, it should be protecting you for the entire season. Phase 1 trial, it reads ongoing, but actually it was just finished, and what's special about this, why it deserves an honorable mention, is that it's aimed at low and middle income countries. So one of the questions before, and that was also answered with, is it for the entire world? Well, this one is aimed specifically low middle income countries and not high income countries. Moving on to our next column, so the maternal vaccines, the one that we're going to talk about is the RSV Pre-F. So it's a bivalent vaccine, which means that it protects against both substrains, A and B. And there's been more recent results as well. So it was effective in a CHIM, so in a controlled environment, but also when administering it to over 7,000 women, there were showed to be 53% lower incidence of visiting your doctor and 71% lower incidence of hospitalization. Again, this is at 5 months, so to compare it to the monoclonal antibodies, because we want to protect over a whole season. This one is produced by Pfizer. And as you may know, Pfizer had a massive advantage because the JSK study was halted actually almost a year ago now, or over a year ago. There was another maternal vaccine, which also was a bivalent pre-F protein, but due to safety issues or safety signals, this trial was halted. And so Pfizer has their own or sort of monopoly in that field at this moment. So the big question, monoclonal antibody or maternal vaccines. I am fully convinced that there's a use case for coexistence of these two, even within countries. So if we look at the pipeline in 3 years, what do I personally expect? There's a lot of advantages for monoclonal antibodies. First of all, what if the child is premature? Then there wasn't enough time to actually transfer the antibodies over the placenta, and so we need to protect them in a different way. The duration, it is thought that the protection through monoclonal antibody administration will last longer than if it was given over the placenta. What if there was no maternal vaccination? We still need a way to protect those people. Or, for instance, if there are immunocompromised patients that were born a lot longer ago than the antibodies would protect you. Mostly also what we've seen with COVID and what's been discussed before is that there is variability in your seasonality. So if that happens, we want to be able to respond to that. And so a monoclonal antibody gives you that freedom. On the other hand, the maternal vaccine is good because it has the end user is, so, sorry. It's good because the mother can decide to vaccinate herself rather than to vaccinate her child. And so even though you're protecting the child, you're not harming it by the administration. Also, if we're looking at viral resistance, and I can come back to that later if there are still open questions about that, it's less likely to get viral resistance with a maternal vaccine than it is with monoclonal antibodies. And there might be, we just don't know yet, but there might be protection in subsequent pregnancies as well. Then what about the future pipeline? So we are about to have, at least nirsevimab is expected on the market soon. We think that the maternal vaccine will be on the market soon, but what then? What if we're at the summit of our challenge? What do we do now? So vaccine uptake is more than just efficacy. It's more than just safety. It's also about what delivery strategies work in your country or in your region, and what are the costs. Besides, maybe even also an important point is we can aim for maternal vaccination, we can be really happy about it, but what is the maternal vaccination uptake currently in your country? What is, for instance, the pertussis or the flu vaccination uptake? And why do we think that that would be any different for RSV? What kind of awareness do we need to raise to get that uptake increased? A question I often get is, what about palifizumab? As soon as nirsevimab comes out, what will happen to it? I think palifizumab will remain on the market. First of all, because what has been pointed out before is that even though it's been used for 25 years now, we don't really see any resistance. My nuance that I'd like to bring in that is that we haven't really used palifizumab all that much. It's really expensive, so it's really reserved for those who are most vulnerable. And we don't know what will happen if we put a whole bunch of pressure on the virus. If we start all of a sudden in the whole world, or at least in part of the world, protecting all children with nirsevimab, we don't know what's going to happen. In the lab, we see that there might be viral resistance. But what about in nature? We don't know, and so if something like that happens, palifizumab can be sort of a backup, and because we know that it will not cause viral resistance. We also know about global demand. So yes, nirsevimab is coming out, but we think it's going to be quite expensive. They don't, or at least AstraZeneca hasn't given a price just yet, but it's not expected to be affordable in low and middle income countries where the burden is highest. So palifizumab might be available for areas where nirsevimab isn't. Now, what I think would be a really nice opportunity is to look at a drug cocktail. So in that way, we can also look at all those resistance that we see in the lab. Maybe we'll see less of it if we have several antibodies that are targeting several different epitopes, and therefore resistance will not necessarily be a problem. Now, these are a lot of bullet points, so just bear with me. My point is that there's a very large mismatch between the burden of RSV, which we've all concluded is in low and middle income countries mostly, and where the pipeline for candidates are actually focused on. So there's, in preclinical studies, phase 1, phase 2, phase 3, most of the trials are aimed at rich countries. So how do we get global access to these immunization strategies? Well, first of all, we need more globally representative trials. Trials should not take place just in high-income countries, but all around the world, so that we can see if there is heterogeneity based on geography. We can consider differential pricing mechanisms based on, for instance, the income of the country. We need to have way more genetic surveillance because we just don't know about resistance. We can speculate, but we don't know until we see it. We've known from the past that there will be a regulatory drug lag. If nirsevimab is out here in Lisbon in this season, that probably means that it's out in the rest of the world later by at least several years. We need to increase the chances of uptake, and the only way to do that is to increase awareness. Just ask any mother around you if they've heard about RSV, and chances are that she will say no. We need to change that. a really good question before was about the costs, but what's also important is the cost effectiveness. So how can we need more data on that, both in our countries here in Europe, but also in lower middle income countries, and there's just data missing. And lastly, what we don't have right now is a correlate of protection. So how many antibodies does a child need to be protected against RSV? And maybe if we start rolling out more ways of measuring this, we can also start knowing how much we need to protect children and if they, for instance, need a second dose. Now, to go to my conclusions, we've talked about the past and how we've tried many different routes on the 7 peaks of the Dent du Midi, and we've actually found 2 at this moment. We've talked about the present, how so much is in development. And we've talked about the future and how do we reach this beautiful view of reducing mortality and morbidity, but let's try to do that for all children. I'd like to end with a quote from Barney Graham, the one who also discovered the pre-F, that we have cutting-edge science to make vaccines, but will everyone benefit? This was in regards to the COVID-19 vaccines, but actually I think this is very applicable to the RSV vaccines as well. I'd like to thank my whole team in Utrecht, but also the RSVNet Foundation, and I'm happy to take your questions in a little bit.